Hi, welcome everyone. If you're just coming in, we're going to give it a couple more seconds for everyone to join us, and then we'll get started. Okay, it looks like most have joined, so we'll go ahead and get started. Welcome everyone to our webinar today. I'm Jenny Gaines. I'm the F.E.A.S.T board chair, and I'm really happy to be here today with our panel of experts. Our topic for today is let's talk about family support for autism and eating disorders. We're very fortunate to be joined with some leading experts on eating disorders and autism, and they're about to get started with their presentation. And before that, we just are going to follow a couple of guidelines. When you joined, your microphone was muted and your camera was off, and we just ask that you keep it that way throughout the duration of the presentation. And also, please put any questions that you have as the presentation is going into the chat box. And if we have time at the end, I will go back and find your questions and ask the presenters to answer them. I also ask that you keep everything in the chat to questions on the topic and not have any kind of side conversation. So it'll make it easier for me to find your questions at the end. And with that being said, I think that we can turn it over to our presenters today. And thank you again, all three of you, so much for being here.
Thank you. It is my absolute honor and delight to be part of this panel. I'm Tchanturia. I'm professor of eating disorders in King's College London and lead clinical consultant for National Eating Disorder Service. And today I'm going to talk to you about autism and eating disorders and keep it very, very brief for about 15 minutes to try to explain to you what we have done to make sure that our community with eating disorders and autism are better supported. And I will talk to you about Peace Pathway, which is acronym which our collaborators developed. We developed it with carers, clinicians, and patients who have autism and eating disorders. And it was pretty much driven by research. We accumulated for years clinical audit in our service and needs assessments. In other words, qualitative evaluation of what community needed. And then we developed this autism-friendly eating disorder clinical pathway. So Jenny already briefed us that most of attendees are parents. And I think we have limited time today, only 1 hour. So I will start from practical bits. We have published the book in 2021. We have produced up to 40 peer-reviewed papers only from my lab, but you will find out that Fiona, who works in Scotland, they are doing a great job to do more work and strengthen the evidence around Peace Pathway. We have social media platforms, and most importantly, this Peace Pathway, I put here web address, has lots of free resources for clinicians, patients, and carers. So you can use all these free resources. If you click and visit website, you can use various handouts. We are signposting for useful information, and hopefully this resource will give you better understanding and more detailed information, and you will find what we know so far. So Peace website is really international. Unfortunately, I only started to monitor it for last 3 months, although this website exists 4 or 5 years. And in 3 months, we identified 11,000 users. So they are across the world, and we are actively looking for feedback, how we can improve it for you. So if we think about autism and eating disorders, this is an emerging topic. We are developing it and pushing further, but what is the evidence why we do bother with this clinical pathway, and why we are putting so much of our energy and effort to make it even more accessible and even more important for the eating disorder professionals and community. First of all, quite a lot of pointers from research evidence. We noticed for years that people with eating disorders and autism have similar cognitive features. For example, inflexibility, rigidity of thinking, difficulties with expression of emotion, social anhedonia, lack of pleasure to be with people, or social anxiety. And this also leads me to other reality, which is clinical reality, where we are monitoring what people tell us or what their clinical outcomes are. And it is now robust evidence that people with anorexia in particular and autism have longer duration of illness, as well as poorer eating disorder and functional outcomes when it comes to audit and when it comes to evaluation of our treatment outcomes. And we know in the UK there is longer clinical service use, and this also drew our attention. So immediately I want to give answers to some of the challenging questions, what we can do, how we can make it easier and more effective treatments we have. First of all, we need to think about reasonable adaptations of environment, of the clinical care. We need to think about communications, and we need to think about sensory systems when it comes to autism and eating disorders when they coexist together. Now, I already mentioned that treatment outcomes are not great for patients with autism and eating disorders. And we have overrepresentation of autism in anorexia nervosa in particular. We know that almost a third of our patients have higher autistic traits, and sometimes they are officially diagnosed with autism. So autism is a neurodevelopmental condition, and we would like to think about autism, and autistic community thinks this way, that brains are wired slightly differently. So we have on one hand neurotypical development, on the other hand neurodivergent brains and neurodevelopmental conditions. This does not suggest that autistic people have deficits. It's not true. We are moving away from this definition. Autistic people, in fact, have lots of strengths. Most of our patients in our clinics are highly functional, and this is true that over years, even in autistic field and autism experts neglected female phenotype of autism, because females with autism are very different from male presentation. For example, we know that females have special interest to social interactions, relationships. They mask better, they camouflage better. They can appear as very able socially, but it comes with expense. And there is lots of wonderful research going on in autism field, and we are trying to engage with autism experts and learn more about female presentation of autism. I will move on straight to the peace pathway development and how we tried to adjust and understand a little bit better eating disorder and autism coexistence. These are first researchers alongside with Maudsley, who helped us to interview patients, clinicians, and carers to understand what needs were in this community, what were unmet needs where we needed to put more work and more research and more development of resources. So here I summarized themes which came out from these qualitative assessments, and I will draw your attention to several aspects. For example, all main stakeholders, patients, clinicians, and carers highlighted for us that we don't pay enough attention to sensory difficulties people are experiencing. They also highlighted that people with autism might need a little bit more time to process therapy sessions. They need some visual aids and other flexible, personalized approaches. And we also identified that sometimes eating disorder professionals and clinicians might need little more training around autism and neurodivergent population. What we learned from carers, this will be particularly interesting for you. What we wanted to find out in our qualitative assessments to understand carers' involvement in treatment process, their views on pros and cons about current treatments, and gather more ideas how to support them better. And we learned a lot, and to cut very long story short, what we tried to shift in our treatment strategies to use more direct language rather than metaphoric language, because people with autism might find it very difficult to follow all therapeutic metaphors. They might find very difficult open-ended questions, and they might need longer process, as I said. We found that written communication is sometimes really helpful, visual aids, some dietetic adjustments, and all these changes were based around needs assessments we did with main stakeholders. If I have to suggest one of the practical tools, I would highlight communication passport, because what we do increasingly in our clinics, we try to build up relationship with the patients from very beginning of the treatment and explore what are their communication preferences. And there is very detailed paper, and you will find communication passports on the PEACE website. So I will not go into details of describing how this work is done. In terms of scaling up, in the United Kingdom, we have now quite a few adopters, early adopters of Peace Pathway, and Fiona represents Scotland. They are doing an amazing job adopting peace resources and expanding this. And we have in the south of the country, Bob Peace Pathway, which tries to adjust some of the resources for children and young people to make this age-appropriate adaptations. I would like to stop there, and with this very broad overview, leave room for other presentations, and then I prefer us to have discussion and cover some of the questions you might have. So I will stop sharing here and move on to Maudsley's presentation.
That's right. I just need to work out how to share my screen. So, we practiced before. Oh yeah, I got it. Here you go. And can everybody see that? Can people hear me and see the screen? Yep. Oh, brilliant. Okay. Thanks very much, Kate. And thank you very much for inviting me and us to talk today, F.E.A.S.T. So I'm Madeline Oakley, and I've been researching carers on the Peace Pathway, which Kate has just described, for the last, this is the 6th year I've been doing this. And just to tell you a little bit about my own background. So my professional background was as a family systemic and psychoanalytic psychotherapist. And I ran mental health studies courses at King's College London. But then I was already a psychotherapist, and then I became a sort of parent to a young adult son who's got autism and other conditions. So he's had struggles with food most of his life. And I'll talk a little bit more about that in a minute. But the reason I'm here, I think, is to talk about my research about family carers' experiences and what we've offered them over the last 5 years or so. And just to say, my research has been conducted online so that carers have been able to access it from all over the UK and some from outside the UK in countries such as Ireland, America, Australia, and so on. So my own personal carer journey. So I wrote about this in the book that Kate just mentioned. I wrote about my shock at becoming a family carer because I was used to working as a therapist, helping others in this position. And it took me a while to realize that I actually might have some ideas to help myself in my sort of carer journey. And that then it took me even longer to realize these might be helpful to other carers. So I guess the combination of being a clinician, but also having a son with autism and other conditions. So the other conditions, he's also got a learning disability, he's got anxiety, he's got epilepsy, and he's always had issues with food. And in the book chapter I've just mentioned, I write about one point when he wouldn't eat anything apart from chocolate-based foods. And it was such a sort of anxiety-provoking moment for me, and I really didn't know what to do. I was on holiday in France. But so I've got the sort of lived experience, I guess, of the autism and the eating problems. So what I did in terms of my research and the aims of the research on the Peace Pathway, I wanted to develop help that was online so everybody could access it for families whose loved ones had autism and also eating disorders at the same time. And like Kate has described, the first step in that was to find out what these carers wanted. So what had been their experiences so far of getting help, and what would help look like to them, and what really did they want. And so over the past 5 years, I set up many groups, probably about 8 different groups and workshops in different formats, And I've taken surveys after each group, held focus groups and so on, just to see what carers liked and wanted. So just to sort of recap, so when we interviewed, these are sort of 3 publications we've got about what carers wanted. So Kate mentioned first one, and that was Adamson and the rest of us, and then Emma Kinnard and the rest of us, and then myself. It was about the coffee groups, the first coffee group, the prototype, I guess, that we offered. And basically, there was a kind of consensus among carers that existing eating disorder services were designed for what the carers called neurotypicals, that they hadn't taken into account the autism. And the carers wanted tailored interventions which took autism into account for their loved ones and also for themselves. So giving a little bit more detail about what that meant. So I'm focusing on what the carers wanted for themselves here. They wanted mentoring by other carers who had lived experience. They thought that the lived experience was really crucial because most carers expressed some kind of frustration with clinicians, that somehow the clinicians didn't get it. Now, I think one of my recommendations is that, clinicians find out more about autism, but also another recommendation is that carers find out more about autism and other conditions as well. It's about sort of skilling up. So going back to what the carers wanted, they wanted more knowledge about the 2 conditions, autism and eating disorders. They wanted connections with other carers, and this proved to be really, really crucial. They wanted respite for themselves. They wanted peer-led support, so that means people with lived experience leading the support. They wanted better signposting for help for carers and a kind of roadmap about what they should expect on their carer journey. So putting the feedback into action from these 3 studies, like I said, I offered a series of online support groups and workshop sessions because in essence, the carers were saying they wanted support, but they also wanted knowledge. So we advertised these workshops via the Peace Pathway Twitter profile, which anybody can access all over the world. So as I said, mostly the participants were from the UK, but also from other countries and from other time zones. And that was really interesting. So I tried out different formats, tried once a week, first one for 9 months, then weekly for a shorter period of time, 4 or 5 months, then monthly for 9 months, short term, long term, 2 hours, 1 hour. So different variations, and all the time asking each carer to fill out a survey and then running focus groups at the end of each workshop series. So really what carers seem to like the best, so they like the workshop, the support groups, but not too many people. So they wanted smaller support groups, but they didn't mind the workshops being bigger. So the thing we came to at the end was to have a workshop where I sort of covered a topic each week and then have a coffee break, then have a support group immediately following the workshop. So this is a kind of combination of advice and support, workshops followed by support groups. So just to tell you a little bit about the workshops. So these were sort of, the topics were the following, and they were run on Friday mornings, 4 consecutive Friday mornings. People, carers seemed to like that. They said they were sort of near the end of the week. They had, could take stock of the week and take out a bit of time for themselves. Like this was a sort of 2-hour sort of package. So the first workshop covered something called the value of low expressed emotion. And that's something that's been written about in that book chapter I mentioned. It essentially means how to step back from your carer role and not to be emotionally over-involved. You might think that's all very well. It's a sort of complex package that we carers need to sort of unpick and work with all the time. Anyway, so that was kind of like the first idea I had, and that was from my training, family therapy training background. And it really seemed to work for me. And I have to say the carers found that incredibly helpful as well. So just how to step back. And in essence, it means behaving a little bit more like a professional would at times with your loved one. Might sound a bit cruel, but I think it means that the interactions you have with your loved one can be less intense, and you step back, you're protecting yourself, and the reactions are sort of less intense to the loved ones. So the next topic was called nonviolent resistance. This comes from family therapy as well. And it's really not that different to the first topic. And it's the importance of de-escalating conflict. And how do we do this? How do we cool things down? And also in that is the importance of support networks and self-care for the carers themselves. So that's really sort of stressed. The third thing that carers liked was something called ACT, acceptance and commitment therapy. So that's a type of CBT therapy. And essentially it's helping carers to look at what can and can't be changed. So helping carers accept what can't be changed, but think about the sort of small tweaks that can be changed, which means that the carers can make sure that their lives reflect their values more. So it involves carers saying, well, what are my values? What do I want from life? And how can I make sure these are put into action? And the final topic was autism and eating disorders and learning more about those two conditions. And seeing autism as a neurological difference and how does this work throughout the lifestyle. And, when my son was first diagnosed, we were still in the era of the refrigerator mother and, it was all about deficits. So this is very different. I think we're lucky that we live in an era where autism is seen as a sort of neurological difference. And just to understand more about how that might affect the person, also learn more about eating disorders, some of the overlapping features, and how might this work in terms of the family, because we found that most of the help and interventions are really directed at children, families with children, and not adult children and families. And as we know, autism is a lifelong condition. So what were the support groups like? So I used a combination of my background, I guess, as a psychoanalytic therapist and just creating this kind of secure base model where it's a sort of safe space. Each carer is invited to check in, how are you feeling, beginning of each group, and then giving the space to the group with me sort of moderating the group to make sure that each participant had a chance to talk. I always shared that I was an autism carer as well as part of the process. And I think in a nutshell, the carers really appreciated the support groups following the workshops, because sometimes feelings came up from the workshops and they could share these with other people in the same situation. And I think most importantly, they're able to make new social connections. And I'm really happy to say that following each group, a WhatsApp group was set up between the carers and they made lasting connections. I know my time's running out, so I'm going to start going a bit quicker. So just general feedback, carers valued the format and the content of the workshops. Some people said, well, in person would be better, but all agreed that being online meant that they could all attend most of the time. And sharing experiences with other carers in the support groups gave the carers more hope, more confidence, sense of optimism, and carers felt less isolated. They liked the workshops because they learned new information and build relationships with other carers. And one of the things that carers found helpful was getting new ideas and strategies from workshops, but also groups, hearing and listening to other carers' experiences. It made the carers feel more confident about problem solving. In essence, the carers felt they weren't alone and made lasting friendships and connections with each other following the workshops and the groups. So just conclusions, carers would like to be facilitated to connect with each other and skill up. Like I said, online groups meant lasting connections with other people who've had these kind of very niche experiences, therefore niche knowledge. Often carers knew more than clinicians, but essentially a non-judgmental because they're all in the same situation. What I found was there was a huge amount of lived experience, resources, and expertise within each unique carer group. Online format made it easy to set up the groups. And I guess one of the things is if you're going to run groups, you need peer carers who have some kind of professional knowledge and resilience to lead the workshops and the groups. And I guess the research overall highlights the importance of lived experience of carers, of being part of that triangle, what we call triangle of care with clinicians, service users, and carers. And just to end, autism can't be changed, but adaptations can be made for loved ones and can change, and for carers, and change the ways that they deal with the autism and the concurrent conditions. and better networks for carers, and improve their own self-care. So carers have some agency in being able to change some of these things to make lives easier for themselves and their loved ones. And that's it for me. There's some references, publications that we mentioned. I'm going to stop sharing now. Thanks very much.
Great. I think it's me now. Please let me know if you can't hear me. My name is Fiona Duffy. I'm a psychologist. So I work partly in clinical practice in a child and adolescent mental health service with young people with eating disorders, where predominantly I use family-based treatment, and also within a research capacity. So I'm the co-lead for EDAC, which is the Eating Disorder and Autism Collaborative. It's a research network to support bridging the gap between autism and eating disorder research. Okay. So what I'm going to do is I'm going to talk specifically about some research which we're doing at the moment, which is looking into eating disorder focused family therapy with autistic young people. So these are some interviews that we did with clinicians. We're also about halfway through our interviews with parents and carers. Still looking for more parents and carers. If people are interested, you're very welcome. Please go onto the EDAC website. And we're also doing some interviews with young people as well. And this is specifically kind of FBT or FTAN for anorexia and bulimia for autistic young people. And I suppose it came really clinically from the idea that it just felt as if we weren't always getting it right in terms of for some autistic young people, and we really needed to think in terms of how to do things differently, I suppose. So I suppose what I wanted to do is really practical in terms of thinking about what have we learned so far and thinking about how that could be transferred in terms of into thinking about parents and carers as well. So the first thing to think about is that the main thing which came across was autistic young people just need more time in treatment, both to support communication, but also information processing within appointments as well. So by that, I mean, if you are breaking down your communication and you're supporting a young person to really process the information that they're given, naturally your appointments, or the content that you're going to get through your appointments is going to take more time. But also what we found is that you needed to expect a slower pace of change, as well as the kind of lots of the feedback that we're getting from both clinicians, parents and young people as well, really to reduce that overwhelm in terms of that rapid change that takes place as well within treatment. So recognising you might need to do multiple sessions of appointments rather than trying to overwhelm someone with too much information all in one go. And also this idea of actually there's some things which actually do need to be treated urgently, but then for other things actually we might need to think about the pace to slow that down, and the goalposts might need to change as well. The main thing which came up in terms of particularly for parents as well was the need for a far more collaborative approach to reduce that overwhelm associated with making rapid changes. So this is a lovely quote from a clinician, this idea of we need to find the ways to still hold the non-negotiables, but be presenting in a choice and kind of collaborative tone. So I feel like clinicians can get really stuck in saying that this is how it has to be and not feeling that they have permission to slightly change the semantics of how things are set up, or even the way that it's set up as well. So it's this idea of how, even within the context of non-negotiables, do you present them with thinking about choice and the collaborative nature as well. Also talked lots about the challenge of differentiating autism and eating disorders as well, particularly within the context of if you've got a young person who's quite acutely starved, and that dilemma of how do you differentiate what's an autistic trait, but also what's a component of starvation. And definitely the most recent research is showing us that actually those who are very high in autistic traits actually continue to be quite high in autistic traits even after weight recovery as well. So we need to take that into account, although obviously there is an impact of starvation as well. But it's also more difficult because this idea of you need to respond very differently to autistic traits versus disordered eating. So this idea that actually we're not attempting to change autistic traits, and actually these are things that we need to be embracing and think about a young person's character and interactions. But actually, how do we do that alongside thinking about the components of the eating disorder which actually needs to be challenged? And actually the really difficult bit is the bit which is actually in between. So yes, there's a need to differentiate and understand autistic preferences and traits, and also the eating disorder component. But actually the bit in the middle, and what lots of individuals' lived experience will tell us, is actually I am autistic with an eating disorder, and that the two interact. And it's beginning to formulate and to think about how to tease that apart as well. But this was a clinician just really highlighting that even very early on in treatment, when there's a real priority of life and death issues, you still need to create a space in understanding what's autism and what's the eating disorder. Lots of individuals were talking also about the need to use the expertise of the young person and their parents. So this idea of actually using the young person far more collaboratively to share their experience of being autistic with the family and the clinician. So absolutely using the knowledge of the family and the child, but also using the child's knowledge to upskill parents in their autistic identity and also clinicians as well, and thinking about what you need from parents at that point of view, especially if the diagnosis is new. And definitely this is my clinical experience as well, is that the vast majority of young people I see within my eating disorder clinic who are autistic, this is their first presentation in terms of to services, and again, because the high proportion are female as well with that autistic kind of phenotype, that actually the autism wasn't really considered either in terms of before kind of their presentation, although obviously parents have kind of adapted and been aware of things as they've grown up as well. But this idea that you also need to draw on the expertise that parents are bringing about their autistic child as well. So this idea of ways to parent a child who's autistic, and actually we really want to be drawing on those strengths and that knowledge from the family, and even more so to be helpful in thinking about how we get eating disorder recovery in the context of having an autistic child. So this idea of that you cannot just put the fact that you've got an autistic child at the door when you're doing an eating disorder treatment and thinking about eating disorder recovery, and how do we actually support recovery within the context of having an autistic child. Talk lots as well in terms of the clinicians and parents were talking about their historical experiences of parenting an autistic young person that families bring, and particularly those with an experience of a young person with quite a kind of demand avoidance profile, so feeling very overwhelmed when multiple demands are kind of placed upon them, and how different a style of parenting that might be that a parent is used to in terms of supporting their young person to manage and navigate day-to-day life in comparison to the parenting style that you need when you're actually supporting very rapid refeeding. And actually, that's a real clash there in terms of parenting styles. And how do we navigate that in a collaborative way, working together, rather than an expectation of a parenting style which is very not in tune, I suppose, in terms of with an autistic young person. The other thing which came up quite regularly as well was the consideration of thinking about neurodivergence also across family, but also across the therapeutic context as well. So by that, I mean considering neurodivergence within families. So we know in the same way as eating disorders can run within families, we also know that that's the same with regards to autism as well. So not just considering the autistic young person, but actually thinking more systemically as well about some of the work that you're doing. I would say as well that that includes clinicians too, and this is incredibly important. So we, as part of our interviews, a number of the clinicians were also talking about the fact that they were also neurodivergent, and highlighting that actually some of the therapy techniques that they might be using within FBT or FTAN might be actually quite problematic for autistic families. So, for example, the use of externalization, which is quite a common technique within eating disorder treatment, is a very abstract concept in terms of for autistic, an autistic profile in terms of being able to use. And it's thinking about, well, how do we maybe use some of the underlying principles without having to have this big abstract narrative that goes alongside it. Similarly, the use of circular questions, which is very common in FBT, which would be asking your child, for example, how do you think your dad feels about that? And how problematic that might be in terms of, and it's not particularly well aligned in terms of with that autistic profile and way of thinking. Talking lots also with regards to parents about the use of guided discovery within actually quite a lot of therapeutic processes, and how tricky that can be in terms of that taking that non-expert stance and supporting parents and carers to be able to problem solve themselves with support. But actually that's not always particularly well aligned in terms of with that kind of autistic style of thinking and that profile and how overwhelming that can be. And sometimes actually a more directed approach with very clear communication, guidance and scaffolding actually might be more helpful in terms of particularly reducing some of that anxiety and stress early days. As I said earlier, thinking about different neurotypes and the potential for miscommunication between the young person, the family and the clinician. So unintentionally, there's a difference in understanding, which could lead to families experiencing treatment as quite punitive. So by that, I mean, this is a clinician talking about that where the autism isn't recognised, or there's multiple layers of what they would call the double empathy problem in action. So by that, I mean that historically, when people have talked about autism, they've talked about a deficit-based medicalised approach of seeing autistic individuals struggling to understand another person's perspective, Whereas a more contemporary theory or understanding of autism would be to think about this double empathy problem, which is that actually people with different experiences, different styles of thinking or relating to other people will naturally then have different ways of relating to each other. So, for example, if you take two autistic individuals that maybe they actually communicate very effectively well together, and sometimes it's the communication across and between different neurotypes or different styles of thinking or experiences that's problematic. And so it's this idea that actually can make really FBT quite hard because there has to be this good relational base and a shared understanding, and that it has to feel like it's coming from a caring position and not that misattuned punitive position. And this idea that actually what they found is that it's more easy to fall into that latter category as a clinician with autistic young people and their families because of that potential communication misattunement. So in terms of really practical adaptations that's kind of coming out of some of the research that we're doing so far, this is very early days, so we're just trying to build this up with the idea of actually giving far more guidance, both to clinicians, but also to families about what to do slightly differently. The main things which is coming across is this idea of, we talked about earlier, using very plain and simple language. So for example, instead of the classic therapeutic question of how are you feeling today, asking more specific and direct questions. So what do you notice in your body right now? Or what were you doing immediately before your appointment today? Trying to reduce metaphors and abstract communication as much as possible. So some of those traditional techniques like externalization, are they actually understood by your young person? Are they actually helpful? And if so, if not, how do we kind of adapt that and think about that differently? The big thing which came across is this need for more time. The pace of change is probably going to be slower due to that overwhelm with that rapid change process. And also the amount that you can fit into therapy sessions is probably less due to that need to actually really effectively break down your communication and give that time to process info as well. So actually, if you're doing therapy very well with an autistic young person, it will take you more time because of those communication needs as well. However, what we need to get is the balance right as well. So there's a constant fear of causing harm by not adapting. So in terms of this recognition that actually for some autistic young people, eating disorder treatment can be very aversive and incredibly difficult. And so what we're not wanting to do is to cause harm via eating disorder treatment. But there's also this fear of harm by making either too many adaptations and therefore not targeting the eating disorder, or just going so slow that actually you're actually prolonging the length of the kind of eating disorder itself as well. And that's a balance I think that we need to navigate together as a team in terms of alongside parents, carers, young person and the clinicians as well. Thinking also about what are the critical parts in treatment that need to be prioritised and what are other parts that can be paced. Lots of the time within particularly kind of some FBT approaches, it's a feeling of changing everything immediately and as quickly as possible, but how incredibly overwhelming that can be for someone who's autistic. So instead thinking about actually what is the absolutely essential things that need to be changed right now, and what's the other things that actually we can go slower on and needs to be paced. Lots of clinicians and parents also talked about the need to target the eating disorder, but very importantly, the goal is to return to your child's historical eating pattern. So by that, your end goal is not neurotypical eating, which actually sometimes within eating disorder treatment and treatment providers, they're still viewing a young person via that very neurotypical lens. So by that, I mean thinking about, well, what did they used to eat? So if they have never eaten, I don't know, broccoli in terms of their particular sensory preferences, your goal in eating disorder treatment should not be to get to a kind of neurotypical preference around about eating. It should be to return to a historical pattern of eating that a young person has always had. Thinking about how and where did they eat and what did they eat with. So by that, thinking about, well, actually, have they ever really particularly enjoyed eating out in very busy buffet restaurants? So in which case, why is it that that's our end goal in terms of treatment, of being able to do those things, rather than thinking about what some of those historical preferences were? Differentiating between disordered eating versus autistic eating is incredibly important as well. So, for example, some of the characteristics which eating disorder treatment providers might identify as being an eating disorder trait, so for example, scraping sauce off of food or separating food, actually is this historically something which your child has always done? In which case, again, why is it that we're trying to target that as a sensory preference rather than accepting that as part of your child's typical style of eating and beginning to think about it differently? As I said before, what are you aiming to do? What's your goal? And again, moving away from this idea of a neurotypical eating goal to thinking about what your child has historically eaten as. So, for example, have they ever eaten flexibly? Which is a kind of common goal, I think, within eating disorder treatment, is the need to eat in a very flexible fashion. But actually, your young person might prefer structure and routine, and has always preferred structure and routine within their eating process. So maybe it's about embracing more of that structure routine within that refeeding process as well. So reducing some of that unpredictability, which is really helpful for some of that autistic profile, but also for interoception needs. So by that, I mean some of those, that capacity to be able to redispose or understand some of those internal sensations that might be happening. So you'll have some young people who actually have just got very, a lack of experience in, for example, hunger cues, and therefore need far more structure and routine within their kind of refeeding process. But you'll also have some young people who actually are very hypersensitive in terms of some of those kind of internal GI cues. And so, for example, that process of refeeding where you have kind of bloating, for example, is actually more excessively felt in terms of, because somebody is very hypersensitive to those experiences, those internal experiences. The other one as well, which was coming up quite a lot, was the consideration of separated family sessions. So if family appointments together is feeling too overwhelming, then actually from that autistic profile perspective of having multiple people within that room altogether, how scary and overwhelming that must be. And actually potentially having a separated model might be more helpful. And then finally, thinking about what we would call autism affirming practice. So this idea that autism is a difference and not a deficit. And actually the protective nature of an autistic identity. So by that, I mean supporting your young person to think about being autistic as being something which is absolutely different, but not a deficit. And therefore, how do you support them to embrace that identity in a very protective way to help support them as part of that recovery process? And then finally, this idea of actually you're the expert in your child. And you know and have parented them for a long period of time before the development of the eating disorder. And there's a need for you to really make sure that the treatment team harness this as much as possible and to use you as an expert with your autistic child as well. That's all I was going to cover today to allow lots of time for questions. But if you do have, you can contact us after this, and that's absolutely fine to do as well. I'll stop sharing for now. And I think I was going to bump into you, Kate, if that's okay.
Kate, did you want to speak any more? We have a little bit of time, or I can ask some questions because I actually had several questions that came up. Thank you all so much. That was really, really fascinating. And if anyone has any questions, they can drop them into the chat right now. And we have some time for our presenters to answer. So please do that if anything came up for you during the presentation. Go ahead, Kate.
I suppose today's panel, we are collaborating a lot between Fiona and myself, Madeleine and myself, but we are doing this panel very first time. So hopefully what you heard today, these are the themes we thought in the context of the today's talk, today's panel, because hopefully attendees could find resources and more information in the websites we shared with you. And I do know it takes time. I watched the chat box. There are not many questions, but probably people need time to become familiar with the resources we shared. And actually, we will be very interested in the feedback. What would they like to know? What else we could have covered better? Because this will help us to engage with carers community. As we speak, we know that we are invited to do similar work for Australian carers work network and for the BEAT, largest charity in the UK. So this is our first steps to implement, to think about expansion. So everything you will give us as a feedback will be incredibly valuable. That's all I wanted to say. I don't want to use the floor for more information or more slides.
Thank you. We did have a few questions in the chat, and one of them was if you recommend any must reads on this topic.
Well,
It
to
looks like
begin with,
Madeline put something in for us already.
Supporting Autistic People with Eating Disorders by Tchanturia. And a lot of us have chapters in it. I'd really recommend that. Sorry, Kate, but that will be my first recommendation. Shall I put in the chat?
If you would like to sort of get book, but we are very proud. We are producing these free resources accessible to everybody. So I would say, yes, book, but go on F.E.A.S.T website and see what are the resources and signposts, and maybe you can find these free resources helpful. And then if it's not enough, we have long list, reading list, YouTube channels, Fiona's website on EDAC, Bob F.E.A.S.T website. So there is lots of free resource out there. So I would start from visiting our website and then take it from there.
Yes, that's great. Thank you. And I think someone else asked how they can reach you. Someone from Ecuador saying regards from Ecuador, how they can reach you on social media. That may have been on the slide. I'm not sure.
Fiona, would you like to pick it up so I don't take too much?
Absolutely. So I think the Peace Pathway is on both Twitter, but also obviously the website as well, in terms of so you can reach us on there. And EDAC is on, we've got Instagram and also Twitter, and also now Blue Sky as well. So we've got lots of different social media platforms. So I can put the handles in the chat if that's helpful. Yeah.
Thank you so much. And someone's asking how you work with parents who have negative understanding of autism and therefore resist the idea that their child and possibly they themselves might be autistic. So, for example, a fixed view that their child must eat out with the whole family. I think you touched on that, Fiona, but any insight there?
I mean, one thing I would say, and Fiona will add definitely to this, we are not looking for additional label or additional diagnosis. We always discuss with families and adults or young people themselves. You have high autistic traits. We are all on the spectrum. We have autistic traits in less or higher degree. And we are here not to diagnose or give you another label. We are here to support some of these traits and make treatments more tailored to your needs, make communication easier, make sensory system better understood, and use more tools and more strategies to support your recovery journey. But it is not our intention to give extra label to family member or person themselves. But Fiona might have additional thoughts on that.
No, I absolutely agree with you in terms of, and I think it's also about understanding what are some of those fears are in terms of what some of those thought processes are around about autism. And I think there's a huge amount of education that's needed, actually also for clinicians, to be honest, in terms of to step away from that kind of that deficit and medicalized model in terms of and thinking about a young person's strength and also alongside that model of difference too. So I think it's working with families in terms of understanding where that's coming from and why and how to support the child.
Well, I could say something about that as well, I think, because I think we've all internalized ideas about what's socially acceptable, what's not socially acceptable. And even though I've kind of lived with my son being autistic for 26 years, I still feel in social situations, oh, what are people thinking? How should he behave? And I just think the adaptations, that I think has come out of the Peace Pathway research, which is kind of low stimulation, low noise, simple communications, all of those adaptations are really helpful for people with autism. you know, and will make life easier for them. They make social situations easier for them. So I think there's quite a lot that could be done, but I do understand where that question's coming from. I think it's quite an important one. We've all internalized, you know, how we should be behaving, and it's not generally kind of in a very accepting way still, although things have changed hugely over the last 25 years, you know. I think people with autism still find it hard in, you know, particular situations, and there's lots we can do to relieve that and educate others, you know, educate other people, friends, carers, clinicians, you know, about these adaptations.
Christina has a question.
Yes. Have you even found that adaptations for ASD can be unhelpful and prolong or hinder eating disorder treatment?
Well, I would say just opposite. What we found was very interesting. Neurotypicals find some of these adaptations so helpful that, for example, I gave you example of communication passport or sensory screener. Neurotypical patients say, this is fantastic. I would like to have communication passport. If anything, it is other way. Adaptations we made is friendly for neurotypical community as well. I personally never came across any negative feedback to adaptations we introduced because they are not rocket science. As Maudsley and Fiona said, they are very simple, and if anything, it is helpful for everybody.
Great, thank you so much. There's a question about a previous question that I think Fiona talked about. It sounds like maybe some more information, looking at whether FBT Maudsley methods are effective or appropriate for autistics, and talking about how counterproductive it has been to try those with an autistic person who has the PDA profile. Maybe some more information about that.
So there's only been two in terms of kind of almost service audits in terms of looking at this, one by somebody called Stewart and one somebody called Bentz. And really what they found is that at end of treatment, outcomes were the same, but actually one of the things which they experienced was that there was significantly more need for inpatient admissions for these young people. So I suppose what you can interpret from that is that actually something wasn't as effective about that treatment because actually they needed a higher intensity of service to be able to help and support them. So yes, we're aware of that. The research is just not there yet in terms of, and that's what we're trying to build up, but we're trying to do it alongside people rather than it being something which is imposed by clinicians, really. I think what we're trying to do is work with people to think about what's most helpful for them and bring in their expertise. So that's kind of the next steps of where we're going with it.
I would add there is another support for carers. Janet Treasure and her colleagues are doing these carers workshops and support. Recent study, which is in preparation, it's not published yet, what she found was that neurotypical response to carers workshop was much better than autistic families. And this drove her to the conclusion that we need more adaptive models for autistic community and more thinking how to make existing treatments more beneficial for the autistic individuals.
I think we are just almost out of time. There is a question on here that's a general like eating disorder question. So in the interest of time, I think we're going to move on. I just wanted to make the point that I really appreciated you saying that the parents are the experts on their child. That's something that we encourage in parent support here at F.E.A.S.T, but it's so important when you have a child with autism and an eating disorder for the parent to be able to trust him or herself. And that's really hard to do when you lose that confidence. I want to squeeze in one last question for Madeline. based on your research, do you think if peer support groups were offered for parents of kids with eating disorders, that if the kids had both autism and an eating disorder, that would be a supportive space? Or do you think there needs to be a specialized group so that the peer support that's offered is from people who've actually experienced having the child with both autism and an eating disorder?
I think so. That was my research. It's
Okay.
been for carers, parents whose children have got both eating disorders and autism. I think it's a very different situation. They just appreciate being with each other so much because they've got this kind of fairly niche experience, which they all recognize in each other. And if you have somebody who's also been in that situation, who's running the group, I think it's really, really makes a lot of difference. And people don't feel judged, people feel accepted, people make lifelong connections. So yeah, I'd say it's a different thing. Just eating disorders is one thing, but eating disorders and autism, definitely. But I think they're quite easy to set up, and I'm still writing out my research this year. So anyway, I
That's
thank all the
something for us
carers.
to consider. Definitely something for us to consider.
Yeah, I just want to thank all the carers who were part of the research and shared their knowledge and expertise and experiences.
Yes, thank you so much to everyone for being here. Thank you so much to our presenters. I really, really learned a lot, and this is going to become a great resource for us to share with parents on the F.E.A.S.T website. And now I just want to close by saying that F.E.A.S.T relies on the generosity of our community to continue to offer our services and programs. And so if you're able to, we'd really appreciate you going onto our website and offering a donation there. And I'd also love to invite you to our next webinar next month. It's on January 15th at noon Eastern Time. And the topic will be supporting an adult child in treatment. So we really hope you'll join us there. And once again, a big thank you to our presenters. We so appreciate you being here. And thank you to all of you who joined.
Thank you
For
for
inviting
thanks.
us.
Thank you.
Thank you.